Looking more at substance abuse and looking at illegal drugs. So one of the things really important to note with the illegal drugs, and you'll be responsible for, is understanding the different types of illegal drugs and what classification they fall under. So for instance, heroin is also an opioid. So opioid drugs, or what are referred to as your narcotics, are basically opium derivatives. So this is like heroin, even things like codeine, morphine, and they all do act to suppress the central nervous system. So many times, opioids, not heroin obviously, but opioids are used as pain relieving drugs after injury and surgery. And they also do allow for feelings of euphoria, or that excessive pleasant relaxation feeling that people get with it. But so you have heroin, which is an opioid. Marijuana and LSD are hallucinogens. They produce the same euphoria as an opioid would. They also cause tachycardia and hypertension, and they also have effects on an individual's behavior and cognitive processing. Cocaine is a stimulant. So we know what stimulant drugs do. So stimulant drugs do just the opposite. Instead of suppressing the nervous system, they cause it to become overactive. So many cardiac issues oftentimes are associated with cocaine overdose. So and things like hypertension and irritability, possibly even seizures, could come about from the use of cocaine. So just one last word on substance abuse as it relates to illegal drugs. Obviously look at the cardiac issues. So a lot of times the cardiac issues are going to be associated as to whether they're a depressant, central nervous system depressant, or if they're a stimulant. Those many times also your cardiac issues could be affected either way. And cocaine's very much known for the cardiac arrhythmias and things like that. For instance, anabolic steroids can cause hypertrophic cardiomyopathy. It could be a secondary effect of using the anabolic steroids. Intoxication, again, your treatment's going to be based on the symptoms. So you will see that in kind of designing your sign and symptom chart, looking at what you have. And again, many times it's just going to be based upon the type of drug. Obviously, a person's going to have a much different reaction to overdosing on a stimulant versus getting intoxicated on a depressant. You know the signs and symptoms of an overdose of one of those, and again, that'll be based upon the physiologic effects that they produce. Withdrawal symptoms are going to be important to note as well. So again, refer to table 14.5 in your textbook. And depending upon the drug, the withdrawal can be life-threatening. So for instance, with heroin, again, heroin is a type of drug where you need medically supervised withdrawal. Okay, you can't just stop taking it because the withdrawal can actually be life-threatening. For some other drugs, it's not life-threatening. Aside from having the bad signs and symptoms you will have, it's not life-threatening, but you need to be aware of that. All right, looking at eating disorders and disordered eating. So this is kind of a spectrum of an issue, or a spectrum of conditions. So the difference between eating disorders and disordered eating, we discussed this in class when I introduced the chapter, is that when you have disordered eating, that's different than having a medically diagnosed eating disorder. So a disordered eating, okay, not an eating disorder, disordered eating is when athletes display behaviors that are, wrong with eating. So in other words, maybe like an extremely restrictive diet, maybe they binge eat occasionally, or maybe even purge and use laxatives. Those are all different things associated with disordered eating. But in order to have an actual eating disorder, there's specific diagnostic criteria for that. And many times disordered eating will turn into an eating disorder. So that's something important to note. Many times you see this in sports with attention to body weight, body image, weight classes. So for instance, wrestling with males, gymnastics with females. This is more common to see in females, but it can be seen in male athletes as well. Many factors associated with this: long-term dieting, emotional trauma, rapid increases in training. So the athlete may be in a desperate attempt to really get themselves in shape. They start to do a lot of things with their diet that don't end up being functional anyway. A conflicted family environment, abuse, inability to handle stress, low self-esteem, personality disorders. These are all things that can definitely contribute to disordered eating. So it's very important that you discover this earlier. If it's found before they actually develop an actual medically diagnosed eating disorder, it can start to be treated a little bit easier. So some physical signs of disordered eating. So you have weight loss, dry skin, brittle nails. So all things you commonly would see in somebody who maybe isn't getting the right nutrients, vitamins, and minerals. Intolerance to cold, menstrual disorders, orthostatic hypotension, dizziness, constipation are all different things that you would many times see in an individual. One thing to note is you can see certain things associated with purging. So purging is the frequent vomiting. So if they have fatigue, sore throat, abdominal pain, sour breath, and an edematous face, which is basically kind of like a round appearance to their face, are all things associated with purging. One of the things that many times early on, you start to run into a major problem with, particularly with active people, are problems with dehydration and also inadequate calorie intake. So many times people will have very restricted calories when they have disordered eating, and obviously that's where you get your energy from. So they'll start to show signs of that over time as well. So now we get into the actual eating disorders. The first one we're going to look at is anorexia nervosa. So this is when an individual refuses to maintain a normal, healthy body weight. Okay. Again, this is more common in females, and there's specific health issues related to females where this comes about. The signs of this, you will note the individuals will be severely underweight. Not only will they be underweight, but the individual won't be able to recognize how low their weight is. So no matter how thin they get, how much weight they lose, they always perceive themselves as being heavy. And they also refuse to maintain their weight within what would be an acceptable range for their age and height. So that's one of the most outward signs you would see. This does tend to be episodic, which means that it has periods of remission and recurrence. So they could go into a period where maybe they're not having as much of an issue with it, and then other periods where they're doing a lot of the dysfunctional eating habits. They use various methods to carry out the weight loss. So obviously that we typically think of anorexia nervosa, them taking in the really restricted calories, basically borderline starving themselves. However, people with anorexia nervosa may also purge and use laxatives and diuretics to avoid gaining weight as well. So it's not just a restrictive diet. They can use purging, laxatives, and diuretics as well in order to do this. So, and again, all of this can create various health-related issues. So particularly with females, the amenorrhea, or the disruption in the menstrual cycle, could come about. You also have, if untreated, electrolyte imbalances, dehydration, various types of endocrine dysfunction, cardiovascular issues, and some of these individuals can go into even cardiac failure if they're not treated. So bulimia nervosa is characterized by binge and purge cycles at least twice a week for 3 months. So this is where you'll get the recurrent binge eating and purging that will take place. So initially you may think, well, if you have someone with anorexia who purges, what's the difference, or how do you distinguish between whether someone has anorexia or bulimia? Individuals with bulimia typically have normal body weight, so they do actually stay within a normal body weight, unlike anorexia. The other thing many times is individuals who strictly have bulimia don't have a tendency to not develop, when they're female, have a tendency to not develop amenorrhea. So unlike anorexia, where amenorrhea is pretty much a certainty because of the limited restriction in calories. With bulimia, many times you don't end up having the amenorrhea. So those are the two of the differences between the two disorders. A lot of the other similar health conditions, though, could come about. You can still get the electrolyte imbalances, the GI disturbances, kidney problems, seizures are all things that you can get with bulimia. Some other things that you could kind of note in individuals, they could have what is known as Russell sign, and that's when you have abrasions or lacerations on the back of the hand. And that's a sign showing that as they stick their fingers into their throat in order to induce vomiting, the teeth rubbing against the back of their knuckles and hands produces that. And many times, because of the repeated vomiting, the teeth will start to show some erosions on the posterior surface from the stomach acid coming back up and doing that. And they also have a tendency to get inflamed parotid glands. So the parotid glands are just anterior and inferior to the ears, and they will get inflamed and irritated from the recurrent vomiting. So, because this is a pretty prevalent issue with physically active individuals, just to kind of note some treatment management issues in the discussion. Big thing is the recognition. So, general recognition of eating disorders. We gave some of the signs and symptoms. Table 14.6 in your textbook would also be very important as it relates to some of the typical outward warning signs of just eating disorders in general. I mean, really, whether you're picking out whether they have anorexia or bulimia from the standpoint of an athletic training, the athletic training profession, it's not all that important. It's just being able to recognize some of the eating issues initially and trying to help them in order to get further help. Which that's where it sometimes can become difficult. It's very important to intervene. Your intervention, the best thing you could possibly do is just present evidence along with concerns for their health. You obviously have to be very careful with this because individuals who have eating disorders can tend to shut down really quick. And so it's really important, come at this from the standpoint of their health, even their performance, because many times, with physically active people, obviously the physical activity is important, and you could, talk to them. I mean, obviously their health is important, and that's first and foremost, but if you could relate it back to how it will impact their sports as well, that could be something that further encourages them to get help. Very important, if you can, involve the family with the referral. Many times there may be issues within the family that is kind of preceding this as well. So it's important that everybody stays on the same page. As far as prevention, again, it's really important that any time if you could be involved in education of coaching staff to, get them to avoid behaviors that, may not be directly looking to obviously cause any problems for the athletes, but avoiding weigh-ins, make sure that they're not discussing weight loss with the athletes. Everything should always be from the perspective of health, and there shouldn't be coaches discussing inappropriate weight loss plans with the athletes, and that's something you could discuss with the coaches. And anytime as an athletic trainer you have the opportunity to educate the athletes on what is an appropriate diet and what are some healthy ways to to lose weight would be beneficial as well. Clinical depression is a disorder where grief and sadness impairs an individual's daily function. So it's at the point where it inhibits them, it actually impairs them physically, it impairs them socially, so it's a pretty significant issue when you have the clinical depression. See some of the basic things that come about with this, loss of pleasure in activities that would normally be something that would, be enjoyable for a person, body weight issues, sleep issues, fatigue, inability to concentrate, suicidal thoughts. And you usually see this throughout an individual's life through, social relationships, family relationships. This tends to get very into a lot of the things that a person's involved with. The signs of suicide risk are on table 14.7 in your text. It goes through 8 specific signs of an increased risk for suicide. One of the things many times found in individuals that have clinical depression is that they have lower levels of serotonin, which is a neurotransmitter in the brain. So many times, although for treatment-wise for this, counseling and behavioral interventions are important, pharmacological treatment can help as well. So pharmacological treatments will focus on increasing an individual's level of circulating serotonin to help treat this. So bipolar disorder is another mood disorder. So we talked about this in class. It's the recurrent cycles of depression and elation, or the depression and mania, if you will. They call this the manic depressant. So both sides of this are severe enough to cause many issues in an individual's life. An individual can become very productive when they're going through the manic phases or the elation phases, but it could also interfere with their judgment, could cause them to take risks that they normally don't. It also inhibits their social interactions. And various things are associated with this. They see many times issues, again, related to neurotransmitters, particularly serotonin and dopamine in the brain. There's also a genetic component and environmental factors that contribute to this as well. As far as your treatments, medications are indicated to treat this. Many times there'll be mood stabilizing medications to help during both phases of the disorder, both in the manic and the depressant phases. And they can also use psychotherapy and behavioral interventions with this as well.